You know, we really owe all the progress we've made in ovarian cancer to clinical trials. And if we look at over a decade ago, it was those clinical trials that allow us to adopt paclitaxel into the care of women with ovarian cancer, which significantly improves survivals, as we've seen. And then it's also clinical trials, phase 3 trials, that have really made a difference in terms of us being able to take a very cumbersome inpatient regimen and make it a very convenient outpatient regimen with substituting cisplatin, which had a lot of toxicities, with carboplatin, and then taking the paclitaxel infusion time from 24 hours to 3 hours. So that's been extremely helpful. If we then look at what the clinical trials have done further, is really about trying to improve survival beyond that. And so if you look at where where we were over a decade ago, our standard was carboplatin paclitaxel given every 3 weeks. Then people said, well, what about giving maintenance therapy, giving a taxane after therapy ends for a prolonged period to see if we have improved survivals. Indeed, that was done. GOG 178 showed an improvement in progression-free survival. The endpoints were set up in that trial that if there was a difference in PFS or OS, they stopped the trial. And in that case, then we never had the overall survival data because of the number of crossovers and so forth. So the trial was designed with a novel taxane as well as just regular paclitaxel versus observation in patients who had a complete response after initial treatment for ovarian cancer. That was GOG 212, which did not show an advantage for giving a year's worth of extra taxane, either the novel taxane or the traditional taxane. So that took that off the table. The next thing that we looked at was this concept of dose dense. Can we give more therapy over a shorter period of time, higher dose over a shorter period of time, and improve outcomes?